everyone again. We had seen in previous classes about the cardiac anatomy and physiology in brief. Let's have a look now how to assess and what kind of assessment we have to do in cardiothoracic nursing. So what you find is very important in cardiac assessment. One of the very major aspects we are aware about is that there are four criteria. One, when patient is arriving, we are inspecting the patient and we are evaluating on what we observe. Another thing, we come with the contact with the person and we are just trying to assess through the percussion, that is by tapping. And second thing, that is through the palpation, that is just pressing deep or superficial palpation. And lastly, through the auscultation, that is what you can see on the screen, is what through the stethoscopic bells we can hear the sounds and how it is differentiating from the normal that we have to assess. But there are different things before going through. We just have to look for again the just brief anatomy and physiology. And what is the blood circulation? Just have a look. The blood is being supplied to the whole system by the heart and lungs functioning, and how it is being purified. So we had previously also seen the same things. Now let's move towards the cardiac assessment. What we will do, first of all, we have to take the history of the patient, which may include his habits, his living style, and whatever conditions he had suffered previously, that is the health conditions or situations. And then any kind of mental pressure or physical instabilities there in the patients. So what we'll do, that is, I told you previously, that is assessment part. We have to see that mental status, blood pressure or the vitals, which we will see, pulses. Next, inspection we are doing, that we will do for the evaluation of dependent edema. Yes, again, when we are seeing that there is an transfusion of blood through the superior and inferior cava to the heart, and it is having the preload and afterload functioning, but if it is been failing somewhere, that the venous return will be not carried out in an equilibrium manner, then in that case we can see the edema. Next, we will auscultate the sound, and then lastly the chemistries, that is blood investigations, that will be showing certain enzymatic actions, certain laboratory investigations. All these things are being seen in the patients. What can be the risk factors for this? Yeah, definitely age factor. Geriatric patients might be having any kind of cardiovascular changes that can be assessed. Then genders, that is both male and female, may have the greater risk. And menopausal stage, especially the hormonal variation in the females after menopausal age. What is menopausal age? Once the woman is crossing the age over 45 years, and she is not having the proper menarche stage and she has skipped the stage, then that time it is a menopausal status. Then even any kind of history of previous cardiovascular disease or any kind of positive family history of the CHD, this can be included if in family members, for example father or mother might be suffering from any kind of heart diseases. Then any kind of stroke history. What is stroke? Stroke, we know that there is an emboli, or the circulatory circulation is having kind of thrombus in the blood vessels or the micro capillaries, and that is blocking the circulations. Next, peripheral vascular disease. What is peripheral vascular disease? All the blood supplies. I had told you that the lower limbs, upper limbs are being supplied by the arteries, arterioles, lower branches and upper branches, which is supplying. Next, smoking. Why smoking? Again, we know that nicotinic substances are responsible for the vasoconstrictions, and that are like triggering the actions of sympathetic and parasympathetic activities are being deviated. Next, hypertensive condition. Yes, again, hypertension is again leading to the peripheral vascular resistance, and that will again lead to what? Increase in the pressure in the blood vessels, and there will be a disaster in the blood flow system. Next, psychological status. Yeah, definitely. Again, stress is related to what? Vasoconstricting levels increasing, lack of social support, again, depressive conditions. These are all the psychological variations. Low socioeconomical status. Yes, Fine. If low economical status, why we can assure that why there is a kind of variation due to socio-economical, that will be the change in the living standards. Diabetic mellitus, again, it is responsible for the vascular changes. And lastly, BMI is okay. Why it is responsible? If patient is obese enough, so definitely the BMI, it will be variating and it will be increased more than the normal, so that will be again the risk factor. Okay, we have to find out from the history of the patient if he's saying that there is a throbbing pain or stabbing pain, that someone is hitting with a punch. So these are the certain symptoms, what area or what location it is having the pain. So we have to find out the location. If the patient is staying comfortable position, still he is having pain or anginal pain, that we'll study in the next lectures. If he is having the pain in the comfort zone or it is the exertional pain, so we have to find out that. And how it is, like I told you, it is a stabbing or it is a throbbing pain, or is like someone is hitting with the fist, or how much frequently it is occurring, daytime, evening time, during sleep. We have to find out that. What you have to do, like for example, I'm having the chest pain and I'm getting in the rest position, so definitely I'm not having that kind of pain, it will stabilize. But someone even during the rest, it is not stabilizing, so we have to find out what kind of occurrence it is. So lastly, we have to see that other symptoms, what it's doing and what we can do to make it away. So let's have a look to the evaluation of pains. Okay, we are seeing that there are certain locations, how they are being located. Red located areas are the most common areas in acute coronary syndromes. This is because there is a variation in the blood supply from the heart and to the heart muscles, that is because of any kind of blockage. Next, in figure 2, we can see that it has been increased, it has enhanced the area. And figure 3, it is completely covering the pericardium area. So we have to find out which is not sharp pain and it is a jabbing pain, but sensation of pressure or fullness, it is like squeezing, or pain is like just squeezing the cloth and it is having the pain. So just it is a type of pain it is. What evaluation of pain we can do? So we have to find out that distress may be from the chest or both arms. Then it can be even sometimes it is in the only arms, it can be mistaken. See, the location of the pains we can misguided through the pains analysis, that it can be hyperacidity or epigastric pain, we can mistake it with the hyperacidity. Sometimes during arm pain we can mistake it with the arthritis. Similarly, differences, we have to ask if the patient is asked to lift the arms above the head, or heart pain will not be aggravated, then it can be the other causes rather than the heart causes. Any discomfort? Yeah, another location. Once the arm is being covered up, then the jaw, neck and jaw are being covered, both sides, that is in the front or the back, it may radiate. Next, it can be mistaken for the toothache. Okay, if it is a jaw pain, we can mistaken that there is a toothache or a stiff neck pain. It might be because of sleeping or anything. What we can do to test this, that we have to see that if the heart pain is not there on bending the head or neck, front or back, then it can be very originating in the neck. It will be differentiations of toothache and heart attack may be very difficult, so we will go for the further assessment. If there is a pressure or fullness, if you are feeling that there is a fullness in the epigastric region or abdomen, it can be mistaken for indigestion, I told you previously. And sometimes it may be accompanied with the nausea or vomiting also. So this kind of pains can be occurring. Okay, that was the front side or the anterior side we had seen. Let's go to the back side. Again, this is a sign. These are the shoulder blades. Okay, this is a scapulated blades which is having the medial plane. Backside pain is only the sign of heart attack. Back pain, if it is there, and it is between the shoulder blades. It is being experienced with the sometimes tedious work if we have worked with the heavy load work. So it can be, but it cannot be skipped. So we have to protect the use of arms and hands and stooping of the shoulders where we can evaluate the pain. Next, these are combination pain. Let's have a look. In figure 8, we are having the combination pain of arms and the precordial area, that is the middle chest pain. And then here it is the middle precordial pain with the jaw pain. And in the figure 10, there is a combination of all arms, chest precordial area and the jaw part also. So we have to see that it is being not aggravated with the discomfort, or it has to be seen. Okay, we have already seen that it has not to be misled. It is very dangerous to evaluate the pain of angina. That is, angina is a symptoms of myocardial infection. So let's have a look. The pain in the left chest wall is centering on the left side of the nipple is almost never seen in the sign of heart attack. The pain is jabbing sensation, means it is like a jabbing, it is hurting somewhere, lasting or 2 seconds or a single seconds, and dull soreness lasting for few minutes or hour. It can be the combination of two. Okay. We can also see that if acute coronary center pain, it is not positional. Although angina is present with the exercises, yes, if we are going for the treadmill test, or sometimes it will be including the pain of heart and stress or rapid heart rate. Patient cannot be positioned out or make it worse by positioning. Like it is not, I told you that position is also variating or worsening the pain, and it is also not being affected by the deep respirations. Another thing, pericarditis or GI esophageal disease or indigestion, gallbladder, fluidic pain, or any kind of skeletal or muscular pain or pancreatitis are also overleading this kind of symptom. Now let's have an assessment. If these are the organs or systems which are responsible for the pain, we can have the assessment. If esophageal reflux is there, we can see that it will include the substernal chest pain, chest tightness, indigestion, relieving with the GI cocktail, or we are having certain kind of drinks or something, it is relieving the pain. Pleural pain is there, that is between the layers of the lungs, it is kind of, then it will be very sharp, it will be positional, it will increase with the deep breath. If you are having deep breath, there will be a friction and there will be a problem with that. Pericardial pain, left chest radiating into the clavicle area, we had seen that how it was the position, we had seen the landmarks. It will be increased with the deep breath and fever will be there. Simultaneously, gallbladder pain, chest pain, and abdominal pain are indigestional pain. In musculoskeletal, positional or tender to the palpation will be there. In pleural pain, again, sharp positional and increase with the deep breath and catching respirations will be there. Pancreatitis, again, sharp pain, and patient wants to sit and lean forward. He will try to come out of that. So we are seeing that patient is getting the unpositional. Now we can see that I had said that there were various criteria to calculate the patient's conditions, and we will do with the inspection first. We will evaluate what we will see, that assessment of the perfusion. So assessment of the perfusion, how we can do? We can see that each of the organs is supplied with the blood. So we can see that mental status of patient is okay. He is not drowsy, then it's fine. But if there is a variation in that, then that definitely there is no proper blood supply. Perfusion is what? Proper blood supply is not reaching to the patient's organs or systems or cells. Next is blood pressure. We have to count down for the blood pressure. It is high or it is low. Then again, we have to see that there will be lack of perfusion in particular area. Skin assessment, definitely. If the patient is having the lack of blood supply, there will be the color changes, there will be the temperature changes, there will be certain kind of other variation. It can be cyanotic, it can be pale, it can be reddish, or moreover. Next, pulses we have to check. Okay, that is feeble pulse or patient is bradycardic or tachycardic, we have to see that how the heart function is contractile function and the relaxation function is there. So let's have a look towards in detail. In skin and nails, we'll assess for the color, moisture texture, temperature, turgidity. What is turgidity? See, let's have a look. We are stretching the skin. If there is patient is having the return of the skin back to its normal position, yeah, it is a strong turbo. But in geriatric patient, we can see that the skin is not returning to the normal position even after pinching. So that is a lack of turgidity. Color, we will see, I told you, cyanos, that will be bluish color if there is no oxygenated blood supply to the particular part. Then if it is pinkish, it is okay having the blood supply. If it is totally pale or whitish color, that means patient is not having the enough of blood supply. Moreover, we can see capillary refilling, very important. We will pinch the nail bed, and if we are saying that the patient is getting the normal blood supply again in less than 3 seconds, or it is normal. If it is not, it is extending the blood supply, refilling, it is taking or recovering time is more, then there is an abnormality. Clubbing, we can see this nail beds. It is because there is a cyanotic heart disease as well as lung disorder. It is a major sign. Can you see there is an angular deformities, or this is a scoop type structure, spoon type structure, and this is how the angular has been changed. Next, we will come to the palpation, superficial or deep palpation we will be seeing. So let's have a look where all the parts we will. Carotid pulses, definitely if patient is having a cardiac disorder, carotid pulse can be felt first because might be peripheral pulses cannot be assessed easily. Brachial, radial, all these things. Then femoral is also the one part that in ICU patients we are definitely going for the carotid or femoral. Popliteal, these are the popliteal pulses. Then posterior tibialis we are assessing, and dorsalis pedis we are assessing. So pulse intensity, there is the level of assessment. How we are assessing? Just three. Carotid pulse, how we are assessing, there is a pictorial representation. Brachial pulse, how we are assessing location with the two fingers, or it is on the mastery of the assessment. Next is the radial pulse. Here we are assessing the radial pulse. Femoral pulse, you can see that there is a femoral pulse assessment in the ICU patient. We can assess even during ABG analysis, we can see this. Okay, popliteal pulse here. Next, dorsalis pedis and posterior tibial. Here it is, we can assess the position of the patient's pulse. Okay, fine. I hope this is clear. Let's have a look to the intensity. Okay, if pulses, if we are measuring in these all areas, if we are finding no pulse, that means it is absent. It is just impaired or very thready, weak pulses if you are feeling. So that is what at level of 1. And if it is palpable, you can palpate it. You do not have to deep palpate, or it is very soft, then you can see through the it is counted as level 2. And if it is very normal, what we can assess, it is the third level. And lastly, bounding pulse, even though you are not that superficially pulping, but it can be seen bounding over the particular region where the pulse can be felt. So it is a pulse intensity grade 4. So it is again. Next, I told you that if there are venous return deviated because of no proper cardiac supply or no circulatory proper supplements of the blood, so in that case edema can be seen. You can see how the edema is. So we have to see it is very severe, then it is +4 level. If it is moderate, it is +3 level. That can be, we can pinch till half to 1 inch. Okay, so it can be seen like this. Second, +2 level, that is a mild, that is 4 mm at least, that is 1/4 to the half inch. We can pinch and we can see that there is an you can see that it is having the pitting edema, or we can create the pit at this much of inch. Then +1, that is very trace, or 2 mm, it is 1/4 inch. It means there is lack of lack of edema, so it is okay. For edema to be visible, the patient is usually retained with 5 liters of fluid inside the body. So you have to go through that time, you have to calculate the IOUO chart. Blood pressure assessment. Okay, simply think, if you are assessing the blood pressure, it should not be deviated from 5 to 10 mm of Hg. For example, the person is having the diastolic blood pressure is 120. Okay, and then it is differentiating to 125 or something mm of Hg, just has difference of 5 mm of Hg, it is okay. But if it is extending more than that, especially it is dangerous in the condition if it is systolic. Next thing, we have to see that there is a pulse pressure. That is difference between the systolic pressure and diastolic pressure. For example, systolic pressure is 120 and diastolic is 80. So both of the differences is having a 40 mm of Hg differences. That is fine. If it is extending above that, for example, I am having 120 mm of Hg systolic blood pressure, and mine diastolic blood pressure, it is having the difference that is 70. So there is a quite major difference. So again, it is leading to the dangerous conditions. Yes, positioning is very important. It should be always taken at the heart level, but because it should be tight in a proper positioning, so if it can lead to the false readings. Okay, now we have to see that Homan signs. Whenever we are flexing the foot, we have to see that we are examining the patient's edema. So that we are doing a brisk flexion of that foot. If there is a pain in the calf region, so that is what there is an Homan sign, and we are even assessing for the edema also, and this is because of that. So it can be diagnosed with the deep vein thrombosis. Let's have a look to the neck. Very important, jugular vein distension. What happens when there is a return of the superior vena cava? There is a return of the venous blood, and there is no spacing to take care of the blood, because there is already the proper filling was not being emptied next. So there will be no space to get back the new blood which is coming from the system. So that will be leading to the jugular distension. At least if there is the no jugular vein distension should be present at 30 degree. Okay, bed elevation we are doing. So in that case, that should be not more than 30 degrees. And the procedure how to we can do is, we have to elevate the bed at 30 degree, and we have to take two scales, and we have to look at the external jugular vein. That we can learn in the practical sessions. See how they are being assessing. If it is 45 degree, jugular vein distension can be seen here. It is kind of jugular vein distension. Okay. Vertical distance between the pulsation and the sternal angles is being calculated by the two rulers, and we can see the differences. If it is being more than 4 centimeters, then it is like leading to the Havoc conditions. Next, we even have to conditions for the respiratory inspection and the lung auscultations. There we are assessing for the O2 saturations and ventilations. We are assessing the different kinds of lung sounds, so that it will be even included in the cardiothoracic assessment overall. Okay, so this is what about the cardiothoracic brief assessment. I hope it is clear with you. Still